MMS Ahuja, one of the founders of endocrinology in our country. And I would request Dr. Ganapathy sir to read out the oration for Dr. Ahuja, and then we'll invite Dr. Sarita Bajaj.
Professor MMS Ahuja, he was a former head of the Department of Endocrinology and Metabolism, Dean, All India Institute of Medical Science. He played a key role in founding a research society for the study of diabetes in India in 1972 and the Harman Foundation in India. He was the founding editor of International Journal of Diabetes in Developing Countries. He was the chief editor of medical publication series on progress in medicine. They are unique and monumental documentations of scientific work done in India on problems of Indian medicine. The awards he received was one of the most prestigious one was the B.C. Roy Award for Medical Research in 1982, and he was awarded the Padma Shri by the Government of India in 1991.
Thank you, sir. And if we could invite our beloved Sarita Madam onto the dais, please. Can we have ma'am's intro slide, which Dr. Surya Narayan could introduce? And can you go back to the slide that you were projecting? Dr. Sarita Bajaj's, that same slide, the MMS Ahuja slide that you were projecting? Right. Yes, yes. It should come here. Okay.
A very good morning to all of you. I think it's my privilege and pleasure to introduce Dr. Sarita Bajaj, who is a consultant endocrinologist and former director and head of medicine at MLN Medical College, Prayagraj. He was the president of RSSDI in 2016-17, founder president South Asian Federation of Endocrine Societies 2013-15, president Endocrine Society of India 2010-11, editor-in-chief ESI Manual of Endocrinology first and second edition, Professor Sarita Bajaj Oration established in RSSDI UP. So it's a lot of achievements and awards, Lifetime Achievement Award for outstanding services in the field of diabetes and metabolic disorders, Lifetime Achievement Award for contribution to Uttar Pradesh Diabetic Association. She has delivered many prestigious orations, and more than that, established Diabetes Education Foundation at Prayagraj. She's areas of interest include endocrine education, thyroid disorders, obesity. She has more than 200 publications in national and international journals and chapters and books. And she has been editor-in-chief and editor in several monographs and books. And I congratulate Dr. Sarita Bajaj for having achieved so many awards and decorations in her life. A big applause to her.
Excuse me? Pointer.
This is the next one. This is the next one. Previous. Yeah.
I need pointer.
This is central. Long press. Long press is pointer.
Okay. And otherwise,
This is the next one. The rewind. This is long press.
with this I can operate from here also, no? I can do it from here also?
Yeah. Here is.
Thank you to the respective chairpersons and for the kind introduction.
A little on that side, your face is not seen. Let it be there. You move this one. Just little more. Your face is not coming for recording. Little more, little more.
I can't. A very good morning to everybody, and thank you to the Endocrine Society of India for this honor, this MMS Ahuja Oration, and a very, very special thanks to Dr. Hari Kumar as well. So, why am I focusing on dermatology? My husband was a dermatologist, but I don't have too many publications in that field. Actually, excuse me, Dr. MMS Ahuja, of course, he was the founder of RSSDI, and in one of the meetings about, I think almost 1.5 decades back, of course, he knew my husband before he knew me, because my husband did his dermatology from All India Institute, MD Dermatology from All India Institute of Medical Sciences. So he said to me that, Sarita, I want you to write a chapter on skin and diabetes, of course, with your husband. So that was the first step in contributing towards dermatology and diabetes, the correlation. So that is why I chose dermatology as the topic for my oration today. And of course, when I joined All India Institute, of course, Dr. Ahuja was no longer the head of the department, but he had taken the Nehru Fellowship at that time. So these are my mentors in the Department of Medicine, and I chose medicine because my senior told me that I wanted to do pediatrics actually. She said, no, pediatrics is a veterinary science. And yesterday, I think Dr. Sanjay Kalra said that endocrinology is called in veterinary science. I don't know how is that. But then one of my seniors said, pediatrics is veterinary science. I'm doing medicine, so you do medicine as well. So that's how I got into medicine. And these are all my mentors in the Department of Medicine. And of course, we grew up reading Dr. MMS Ahuja's the recent advances in medicine. There were volumes of those. So he was always a figure to be looked up to. And when I joined in the All India Institute, I think it was an absolute honor for me. So this is, I think I'm visible somewhere here. I think I marked myself. Sorry. I think that's me. I think you can see me right there. Can't focus here. Okay. This is at the time of his final retirement. We had a dinner meeting. So this is my homage to Dr. MMS Ahuja. So starting off with the oration, the skin, as we know, is a mirror to several endocrine disorders, from the rare necrobiosis lipoidica diabeticorum, which is definitely associated with diabetes, but extremely rare. There are two photographs of that, to the most common, the shin spots or diabetic dermopathy. As far as endocrinology is concerned, I think this is a typical picture of pretibial myxedema. In Graves' disease, again rare. Of course, Addison's, cutaneous and mucosal hyperpigmentation. The angiofibromas in MEN1, collagenoma, again MEN1, lipoma, again MEN1, then the cutaneous lichen amyloidosis in MEN2A. Again, the typical necrolytic migratory erythema, which is associated with glucagonoma. And if I show you pictures like these, I'm sure this is a spot diagnosis with the typical striae, the acne, the hirsutism, and I didn't have a front photograph to show you the moon faces, but you can see the hirsutism and you can see how round the cheek is. I'm sure I don't need to tell you the diagnosis here. So as far as the skin manifestations of insulin resistance are concerned, these are two recent publications, and the disorders which are associated, which have a strong association, we're all aware of acanthosis nigricans, acne. I will be focusing on psoriasis, but then there are some which have a potential association. These are what we call skin tags commonly, androgenetic alopecia, hidradenitis suppurativa, of course hirsutism, hyperandrogenism, and some which are anecdotally linked, alopecia areata, as well as vitiligo. So I'll just go through those one by one to give you a pictorial. So everybody's seen the velvety, it can be dark brown, it can be black, and quite often associated with skin tags as well. Though the skin tags per se are not so strongly associated with insulin resistance. So in the intertriginous areas, this is very typical. And there are also, you can see acanthosis in the knuckle area as well. So about 25% in the general population, over 60% in overweight and obese children. This is typical acne for you. And acne can also be seen in the back, apart from the face, or in fact the whole of the trunk area. These are the skin tags, which are maybe slightly hyperpigmented, multiple pedunculated, and you can see one giant skin tag again in the second panel. The ones that are potentially associated, this is typical androgenetic alopecia. This is the female pattern, and the thinning is limited to the crown area. This is important. The frontal hairline is paired. It is progressive, non-scarring. It can be present, of course, in men and women, but Asians are less affected. Hidradenitis suppurativa, again, is a chronic inflammatory follicular occlusive skin disorder characterized by recurrent abscesses, draining sinuses, and scarring tracts, with a prevalence up to 4%, and it affects intertriginous body areas, just like acanthosis nigricans. Of course, hirsutism we're all familiar with. I'm just showing you a couple of pictures of typical hirsutism and hyperandrogenism, acne, hirsutism, temporal baldness, and of course this is evidence of virilization, and clitoromegaly as well. Alopecia areata, again a typical picture. It's non-scarring, which involves the scalp. It may involve the body as well, characterized by hair loss without any clinical inflammatory signs. Vitiligo is supposed to be anecdotally linked, as well as atopic dermatitis, which is a relatively newer addition, which is seen more in children as compared to adults. It may be associated with allergic rhinitis or other allergic manifestations. Again, like I said, this is very anecdotally because the association between atopy and metabolic syndrome has not been fully clarified. Right, now coming to psoriasis. So these are the typical, the main feature is the scaling and the plaque formation. This is absolutely typical, and the silvery appearance. So here you can see central obesity along with extensive or very severe psoriasis. So it's chronic, systemic immune-mediated, so we have erythematous, indurated, scaly pleuritic plaques, up to 11% in adults, 1.3% in children. And there is a dose-dependent relationship between the so-called PASI, that is the psoriasis area severity index, and the prevalence of metabolic syndrome. Now, if we look at the odds ratio for severe, moderate, and mild psoriasis, it is 1.98, 1.56, and 1.22 respectively. Frequently associated with comorbidities. So in a meta-analysis of over almost 1.5 lakh participants, or rather 1 million participants, almost 47,000 were psoriasis patients. They had a higher prevalence of metabolic syndrome with a pooled odds ratio of 2.14. And in another systemic review and meta-analysis of 14 papers with about 25,000 psoriasis patients, 31% had metabolic syndrome with a pooled odds ratio of 1.42. It's also connected with an elevated risk for diabetes, hypertension, dyslipidemia, coronary vessel disease, and cerebral and coronary vessel disease as well. They both share a common pathway that is genetic with a predisposition to the inflammatory pathways. The important line is that these pathways are selectively addressed by biological treatments, which have substantially changed the outcomes of psoriasis therapy and affect positively comorbidities, including reduced CV risk, allowing a more comprehensive approach to the patient. So this is the overall burden. My focus will be on the metabolic associations. So some of these are emerging, some are very classic, so I'm not going to I've just listed it here. Some are absolutely classic. The emerging ones I will be focusing on, including sleep apnea. There's also non-alcoholic fatty liver disease, and some are related to treatment, like dyslipidemia, hypertension, and even hepatotoxicity. So there is a common environment here. Both the genes and the environmental triggers are there, responsible for the metabolic syndrome, and especially for obesity is associated, giving rise to, especially if the psoriasis is severe, then you have non-alcoholic fatty liver disease with the other lifestyle disorders and cardiovascular disease and diabetes as well. So common pathophysiology is the genetic, both genetic predisposition and the inflammatory pathway, which involves chronic low-level inflammation mediated by the pro-inflammatory cytokines, which I have listed here. In our study, we wanted to include these, but we were not able to get funding for that. Some studies have implicated IGF-1 as a shared mediator in the keratinocyte proliferation, which is seen in psoriasis, and in the development of diabetes and dyslipidemia. Again, just a cartoon to show you the immune cells and the lipoprotein-associated cytokines, which are implicated in the psoriasis pathogenesis, but I'm not going into the details of this. So this is the study which was published in the Journal of Associations of Physicians of India in October last year, the metabolic diseases and associated complications in patients with psoriasis. So we looked at the prevalence and the correlation. We looked at insulin resistance, whether there is a link between psoriasis and metabolic disease, the association with the severity of psoriasis, and the presence of both micro and macrovascular complications. These were the clinical and laboratory workup, apart from the anthropometry, the blood pressure, the biochemistry, ocular examination, electrocardiograph, 2D echocardiography, and the PASI, that is the psoriasis area severity index, was calculated. HOMA-IR was calculated as a measure of insulin resistance, and the carotid intima media thickness as well. So this is how we decide the severity of, this is a pictorial, very easy way to identify mild, moderate, and severe. The inclusion criteria, all adults with definite conformation. So of course we had, this was interdisciplinary, the Department of Dermatology. Of course my husband had retired much earlier, so we had other people look into it, and these were the exclusion criteria. Because I continued this study over 2 years, so what I have done is pooled the data for the 2 years. In the second year, we wanted to look into the inflammatory markers. Like I said, we were not able to get funding for that. So then we looked into the carotid intima media thickness in the second part. So the total data here, so the mean age is around 40, so these are young subjects. The majority had mild and moderate. Very few had severe psoriasis. The more of males as compared to females. If we look at the clinical profile in totality, the significant differences were in the weight, that is the body mass index, the diastolic blood pressure, the fasting and the postprandial as well as the A1C, the fasting insulin, HOMA-IR, triglyceride, HDL, the liver function tests, and it's not visible way down, but the kidney functions, that is the creatinine as well as the microalbuminuria, were also significantly abnormal in cases as compared to controls. So this is the data for the HOMA-IR for patients with or without insulin resistance. Yes, again significant for the cases. Hypertension, again significant for cases as compared to controls. Obese, more patients were obese in the cases as compared to the controls. The triglycerides were higher in the cases. HDL was lower. More of metabolic syndrome in the cases. And if we look at the data that is available across board, and this is large studies with a large number of cases, both controls as well as psoriasis, the odds ratio for diabetes, for dyslipidemia, as well as obesity are significantly higher. As far as the micro and macrovascular complications were concerned, there was significant difference in retinopathy, microalbuminuria, the electrocardiographic abnormalities, as well as echocardiographic abnormalities. As far as the data on the carotid intima media thickness is concerned, the mean CIMT was higher in cases as compared to controls, and if we look at the mean of the cases, it was significantly higher, and the proportion of subjects who had a carotid intima media thickness of more than 1 millimeter was also higher among cases as compared to controls. So if we look at the cardiometabolic disease in psoriasis, the impact of inflammation on vascular health, again there are good publications. This was this year itself. Patients with psoriasis have an increased prevalence of the classic CV risk factors, but psoriasis may provide an additional and independent CV risk factor, that is inflammation. So again here the data for the odds ratio, we look at the cardiovascular risk factors, whether it's hypertension, diabetes, and obesity, metabolic syndrome. The odds ratio are higher as compared to the control population. Whether we look at the systolic blood pressure, abdominal obesity, triglycerides, and metabolic syndrome, again, for control, even in pediatric psoriasis, the odds ratio are higher in the patients as compared to controls. Now, looking at the outcomes, myocardial infarction, stroke, across board cardiovascular events, coronary heart disease, again the odds ratio are much higher in the psoriasis patients as compared to controls, and this is what is called the psoriatic march. So psoriatic march, or the inflammatory march rather, there's systemic inflammation, insulin resistance, endothelial dysfunction, atherosclerosis, leading to myocardial infarction or stroke. So this is the summary of the observations. So we observed insulin resistance, prediabetes and diabetes, hypertension, dyslipidemia, evidence of coronary artery disease, cerebral vessel disease, and microvascular complications, retinopathy, as well as nephropathy. So there was a positive correlation of psoriasis with insulin resistance. It was observed to be an independent risk factor for development of metabolic diseases, so more of hypertension, diabetes, prediabetes, increased triglyceride, and decreased HDL. As far as cardiometabolic disease is concerned, it's highly prevalent. So the severer the skin disease, the greater the chances of cardiometabolic disease. It is believed to be an independent risk factor for major adverse cardiovascular events. A large population-based cohort study in the United Kingdom demonstrated that psoriasis was associated with an increased risk of myocardial infarction, which was independent of body mass index, smoking, and the other lifestyle disorders. Dose response was demonstrated with stronger, more clinically significant risks in patients with more severe disease, as defined by receipt of phototherapy or systemic therapies, and then subsequently numerous epidemiological studies have similarly suggested psoriasis to be an independent risk factor for these outcomes. So the longer duration is also associated. For example, in this Framingham risk score study to determine the impact, when psoriasis was added to the score, there was a reclassification of a majority of patients to a higher cardiovascular risk category. So 73% of the patients at low risk were reclassified as intermediate risk, and 53% of patients at intermediate risk as high risk. Even aortic inflammation has been observed to be increased in psoriasis in a manner that is independent of CV risk factors, and it correlates with the severity of the skin disease. So what are the implications for management? Although the pathomechanisms of psoriasis are not fully understood, increasing research attention is being paid to the cutaneous to systemic expansion. So what I showed you, the psoriatic march or the inflammatory skin march, and further immunological studies into the genuine master switch underlying the comorbidity are warranted. Is it all just disorders of inflammation, which we discuss under different headings, whether it's diabetes or hypertension or dyslipidemia, endothelial dysfunction, polycystic ovarian syndrome? It's underlying inflammation. That is just food for thought. So this cosmetic disfiguration is, of course, from the patient's perspective, a lot of underlying psychiatric problems. Physicians may hesitate to perform electrocardiogram, echocardiogram, blood exam, even especially in severe cases with extensive skin eruptions, and they are the ones who are more likely to have underlying more inflammation and more of the lifestyle disorders. So these undesirable factors may delay the correct diagnosis and treatment. As anti-TNF alpha treatment is feasible for managing both the skin lesions and comorbidities, early diagnosis and appropriate intervention by physicians in cooperation with dermatologists, so much for interdisciplinary endocrinology, is required in order to increase the physical and mental quality of life. So the list goes on. So I just told you the absolutely strong, even the anecdotally, but you can see how long the list has now become, and more work is going into the dermatological associations with inflammation. So I would just like to end my talk with a couple of quotations. I see a lot of young people out there that you should continue to do whatever you are doing and whatever research is possible. I'm sure you've heard of Veer Das. He's, I think, in the eye of the storm. Yes or no? Who spoke of 2 Indias at Kennedy Center. Yes? Yes. So in the call, he didn't talk about research. He spoke about a lot of things which are very, not very palatable, some of them. But as far as research is concerned, I think the 2 Indias, one is the one who can't, and the other is the don't and the won't. So I wish we could have a better balance there. And okay, if you are less curious about people and more curious about ideas, and if there is really no data, then I suggest you find wise people. And personally, I'm not smart at all. This is my honest feeling. I just procrastinate a lot, and I stay with problems longer. I just don't give up, and I just stick to whatever little I know and whatever little I can do. And the last one, take risks in your life. If you win, you can lead, and if you lose, you can guide. Thank you. Thank you very much.
Thank you, Dr. Sarita Bajaj, for that excellent oration and telling all of us that whatever may be the age, where we are, we can always do research. And it's always so nice that you're still keeping the research on in addition to your clinical work, and it's really great. And thank you again. As it is customary after the oration, we do not have any questions. And thanks, Dr. Sarita.
Thank you. Thank you very much.